Hello, welcome to today's Ed Talks, which is on the use of oil-based intrauterine contrast to enhance fertility. And we have today a global expert in this area, Professor Neil Johnson, who is a subspecialist in reproductive endocrinology and infertility from Auckland, New Zealand, also an Aspire board member, and the professor of obstetrics and gynecology at Flinders University in Adelaide. So it gives me great pleasure to welcome Neil.
Thank you, Claire, and hello everybody, and thank you to Aspire for this lovely invitation.
It's going to be a great Ed Talk, so let's kick off. Firstly, oil-based intrauterine contrast, Neil, is made by a single manufacturer at the moment, isn't it? A company called Gervais. So keeping with correctness, can you just tell us if you have any relationships with them?
Well, indeed I do. I do have that potential conflict of interest in that Gervais has supported my conference attendance on occasions. I've also been the recipient of 2 research grants from them, and I've been involved in advisory boards for them.
Okay, and look, I'm here to keep him in order, but so we're going to try and keep to the evidence. So I guess the first question I'd like to kick off with, Neil, if that's okay, is does oil-based intrauterine contrast improve the chance of a natural conception?
Well, it does, and I think we know this now beyond reasonable doubt. We've long suspected it, even from the last millennium, where at the turn of the millennium, there were Cochrane systematic reviews that were potentially showing some benefit on natural conception from the use of oil-based contrast media versus no intervention. It was our work in the early noughties, between 2000 and 2004, that we published in Human Reproduction, a trial called the Flush trial, interestingly, that looked at that very thing, which was the oil-based contrast medium versus no intervention. We found a significant benefit in the 6 months that followed for natural conception, but approximately a doubling of the chance of conceiving. And this was in a fairly long-standing infertile group, who'd had infertility for 5 years or so, who were of average age about 35. So it was a reasonably entrenched infertility group, and we found that it was even more beneficial, perhaps twice as beneficial, in those who'd had a history of endometriosis. Now, that was also followed up somewhat more recently by the Dutch group, who published in the New England Journal of Medicine in 2017, who also have now shown clear benefit, statistically significant benefit, of oil-based contrast media versus water-soluble contrast media in the 6 months that follows an HSG as a diagnostic intervention, a 40% pregnancy rate with oil versus a 30% pregnancy rate with water-based media. So I think we can say that it does significantly improve the chance of conceiving naturally.
So you've mentioned the way in which it's given, and that's with a hysterosalpingogram. Is that correct?
That is correct.
So what are the pitfalls of using oil-based contrast into the uterus?
Well, if I may just clarify, so we have always been a bit conservative in Auckland, and we've always used it in the context of an HSG under fluoroscopy X-ray screening. There are groups around the world, certainly some in Australasia, Western Australia, with whom we've published actually, who are now also using it under ultrasound guidance, and we can perhaps discuss the merits and otherwise of doing so. And although it's not necessarily recommended by the company themselves, I know of many surgeons, and I have done this myself on very rare occasions, where it's administered at the time of laparoscopic surgery, either hysteroscopic or perhaps a combination of hysteroscopy and laparoscopic surgery. So just getting the Lepardol in there when it's been difficult to otherwise do. But yes, that's right. We've normally given it in the form of an HSG. And you asked about pitfalls. That is to avoid or to stand the best chance of avoiding one of the pitfalls, which is intravasation, where the contrast medium escapes into the vasculature, into the blood vessels, either instead of or as well as going up through the fallopian tubes. It's not the only potential pitfall. So we're on the lookout for a few things. Perhaps I can mention lipogranuloma formation, almost to dismiss it because it's very rare, and that's where the oil-based contrast pools within perhaps a fallopian tube that's already damaged and sets up a bit of an inflammatory kind of response. Like any trans-cervical procedure, there is always a risk of infection, and we need to bear that in mind with any trans-cervical procedure, to make sure that we're not turning chlamydia carrier status, for example, into a chlamydia acute PID. That is not a great day for the patient and for their fertility, if that is to happen. Thankfully, that seems to be rare, and because a lot of the oil-based contrasts, including Lepardol, have a high iodine content. In fact, we actually find that oil-soluble contrast media, HSGs, carry a lower risk of infection than water-soluble contrast media, and there's certainly some evidence in the literature to support that. And indeed, the literature does support that this is a very safe procedure to undertake. One of the things that we've been looking at very closely recently is the impact of the iodine content of oil-soluble contrast medium on thyroid function following one of these HSGs, and we've actually found, and it's a transient impact. It's called the Wolff-Chekhov effect, in fact, and it's subclinical hypothyroidism, which tends to occur. It's more or less a negative feedback impact of the iodine on thyroxine production. But there's about a 40% chance of, often it's very, very transient, but a 40% chance of developing subclinical hypothyroidism in the 6 months following a procedure, and less than a 5% chance. Conversely, it's a bit complex, but there's an impact called the Joss-Basedow effect, which can actually paradoxically cause hyperthyroidism. That tends to be between 3 and 6 months. But all of these impacts, we believe, are transient unless there is some underlying thyroid dysfunction that predisposes a person receiving this to permanent thyroid disease. We don't believe that it's triggered off by this, but we do recommend monitoring, certainly for up to 6 months following this kind of oil-soluble HSG procedure, and definitely once one becomes pregnant. Which often happens.
So you should do the thyroid function tests before you administer it to make sure that they're euthyroid. And presumably Graves' disease or active hyperthyroidism would be a contraindication at that point in time, at least, yeah?
That's correct, Claire. We consider active hyperthyroidism as a contraindication to an oil-soluble contrast medium HSG.
So you do the thyroid function test before and some form of monitoring after that. Any other, and you've mentioned intravasation and you've mentioned infection and granuloma formation. Anything else that we should tell the patients about oil-based intrauterine contrast?
Well, yes, and it is recognized that there is a persistence phenomenon, and that's quite a normal thing, actually. So the The oil-based contrast does not get removed very quickly. It can act as I've hinted already, as a reservoir for iodine, but it can also be seen on X-rays that are undertaken in the future. So it's important that the patients are aware that that is a not uncommon phenomenon. It's reasonably commonplace for it to be visible on a future X-ray, but again, it doesn't seem to cause any problems.
And Neil, how long does the effect of the oil-based intrauterine contrast last? What's the duration of effect?
Well, it's interesting because in our original trial, we found that I mentioned the accentuated impact with a background of endometriosis, and that fertility improvement effect, although dramatic, does seem to be over within about 6 months. We found in our flush trial, or the extension of the flush trial, that the impact was up to 2 years, possibly longer, in those who did not have a history of endometriosis. The Dutch group that I mentioned, who've followed up their New England Journal of Medicine cohort, have found that the gap between the two treatment groups does narrow over time beyond 6 months. So, I think we can probably say it lasts for at least 6 months. So when I'm offering procedures, some ask for a repeat procedure. For some, it's the only way that they can get pregnant, actually, having this done. So I certainly wouldn't be repeating it within 6 months of a previous procedure.
Okay. And how does it work, Neil?
Well, that's been a very interesting question over the years, and traditionally it's been called tubal flushing, and I think that implies that there may be some sort of almost plumbing impact from it. The flushing out of debris, mucus plugs that are not necessarily completely blocking fallopian tubes, but that might be hindering fertility. And of course, the oil-soluble contrast media are quite viscous and probably quite effective at doing that. And I know that the Dutch really largely support that. I'm a wee bit more in favor of an immunobiological phenomenon. I think supported by the fact that it seems to have a differential effect in endometriosis versus those who don't have endometriosis. So there could be an impact, and the Japanese have done studies to suggest that it alters the intraperitoneal environment in a positive way. So improving increasing Treg cells that may be an important immunobiological impact. And in our earlier studies, we have also shown that it can have an endometrial effect. We actually found that it actually, curiously, seems to increase the density of endometrial uterine natural killer cells, which some people might think, well, that doesn't sound quite right. But of course, I think those who understand the function of uterine natural killer cells will recognize that they are the most important leukocytes to be present at the time of the implantation window. And we've also found that Lepidol lowers the expression of endometrial osteopontin, so the molecule osteopontin, significantly and consistently. Now, osteopontin is a ligand for integrins, of course, the little sticky receptive molecules in the endometrium, and we know that women with endometriosis will overexpress osteopontin within the endometrium. So suppression of that may well be sort of freeing up the integrins to make the endometrium a little bit more receptive. And in fact, in the early studies that we did post-trial, post-RCT surveillance, we found in the first, well, it was 296, almost 300 procedures, there were 17 women where we couldn't even get it into the fallopian tubes, let alone through one or the other. And in fact, the pregnancy rate in that group, we knew that these patients had patent fallopian tubes, but the pregnancy rate within that group was just as good. In fact, it was even a little bit better, the crude pregnancy rate, obviously small numbers. But we found that did not adversely impact the pregnancy rate. So that seemed to favor the sort of improving endometrial receptivity idea. Look, there have been other theories proposed over the years: straightening of fallopian tubes, lysing adhesions, perhaps even some impact on sperm-egg interaction, or even on sperm itself, sprucing up motility, etc. We've also become a bit interested in iodine. So in Auckland, we conducted a study called the SELFIE study, Safety and Effectiveness of Lepardol for Fertility Investigation. And we've actually got some preliminary data suggesting that it is those who are iodine deplete when they have an oil-soluble contrast medium, HSG, who are those who stand to benefit the most from this procedure. So the pregnancy rate is higher in those who have a bit of iodine deficiency beforehand, less so if they're iodine replete. So it may be that there are a number of different mechanisms at play.
Very interesting. And so does the use of oil-based intrauterine contrast enhance the success of IVF or frozen embryo transfers?
So that's a slightly disappointing downside to our data. And as things stand at the moment, we have no evidence to support that idea. We did actually even conduct an RCT to look at that, known as the IVF lube study, or Lepardol uterine bathing effect study, in those due to undergo IVF who had either repeat implantation failure or a history of endometriosis. So in other words, those that we thought might stand to gain the most. Now, unfortunately, the trial failed in terms of numbers. So we didn't get the power that we wanted. We only got 70 recruits rather than the 350 that we were looking for. But we did not see a hint of an improvement in the chance of fresh embryo transfer working. And I did wonder whether we were actually looking in the wrong place, that maybe it's embryo thaw that we should be looking at, because let's face it, the endometrium is under a strong hormonal influence at the time of fresh embryo transfer that might be swamping the potentially beneficial endometrial effect of the oil-based contrast medium. We really don't know the answer to that, but certainly embryo thaw to me seems much more like trying to conceive naturally, where the endometrium is under much less of a hormonal influence. And so I think that's where we need to be looking in ART to see whether Lepardol could be a useful add-on. At the moment, we don't know the answer to that question, Claire.
Sounds like an absence of evidence.
Indeed.
Thank you. Time's up. What a wonderful talk, a wonderful appraisal of oil-based intrauterine contrast from Professor Neil Johnson. So thank you very much for taking part in this Ed Talk, and I hope everyone will enjoy this. And any questions or comments, please send them to the Secretariat so that we can engage. Thank you very much, Neil.
Yeah, I'd be delighted to answer any questions. So thank you, Claire, and thank you, Aspire.